This is a bit similar to the first talk about mid-cab, really, and it's to share our early experience with doing the same operation that we've been talking about through a slightly smaller incision, so coming out coming out at the second rather than the third or fourth intercostal space. And this is experiences from James Cook, obviously. So for those of you who haven't seen what a second space mini sternotomy looks like, so this is a conventional incision, obviously, and in this patient, the fourth space is about the level of the nipple, so that's where you'd come to, if you're doing a fourth space, and the ziphus sternum is about there. So you can see this incision just limited to the upper part of the sternum. And we can obviously do this because if you divide the manubrium and go across the junction, stopping at the second space, and you open up your incision, you've got access to the whole of the ascending aorta, the distal ascending aorta, the proximal arch, but of course you've got very little access to the heart at all, or the right atrium. And when we sort of started to think about how we're going to do mini AVR, there are obviously a number of options available. The fourth space, as Suki alluded to earlier, there's very little data to support the benefits of a fourth space as opposed to a conventional median sternotomy, really. And that was certainly very important to us. We wanted to make sure we did an operation that was going to provide something that was better than what the patients were having at the moment. The second space was attractive because it's very much like, a truly minimally invasive incision, as the approach that you'd use for a transaortic TAVI, for example. The other option obviously would have been a thoracotomy, but we thought that a thoracotomy was likely to be more difficult. It's a bit further away from what we do, and it was likely to represent a much longer and steeper learning curve. And of course, there's this issue about selection with thoracotomy. Not all patients are suitable. You have to do CT scans and select the right patients. And so we're looking for an operation that was that was minimally invasive, that was applicable to a wide range of patients without needing to add another step in the pathway to select, and one that wasn't too far away from what we do at the moment. And that's how we ended up doing the second space. So the program's been running for 4 or 5 months now. Andrew Goodwin and myself are doing these operations. And we think this is a really good way of doing it, having 2 surgeons starting at the same time, because it makes it a lot easier to learn how to do a new operation. We obviously thought about it and went to watch Mathieu Glauber do them in Massa, and then we got permission to do them when we got back from the hospital. We started off doing 5 cases together to come up with an operation that we thought we wanted to do. And that way, it was easier to learn from each other when we went our separate ways, as it were. And we now operate separately, but we come together if we think something's going to be difficult. So this is the operative view. I'm standing at the top, taking the picture from the anesthetic side. So the head's there, and the feet are there. And you can see you've got access to all of the ascending aorta through this incision. You can't see the right atrium at all. You see the RVOT and the PA, and this is the flexible aortic cannula in. I also use a CO2 insufflator throughout the operation. So I'll just I haven't got any videos, unfortunately, but I'll try and sort of do a step-by-step description of how we do the operation. So the patient comes in supine, and the first thing we do is the peripheral, the percutaneous femoral venous cannulation. And we do that under ultrasound guidance because we think that's a really important part of the operation to get right. We try to hit the artery at the vein at the right angle because if you don't do that at the end, trying to stop the bleeding can be a problem. Once we've got the sheath in, we wire the vein and under TOE guidance, and we set the wire across the IVC into the SVC, and we heparinize at that stage. We then go back to the top and do the sternotomy. So we divide the manubrium and we stop at the second space, and we make a reverse arrow incision, much like I showed on the first diagram. The rest of the operation then is more or less routine. Our incision, unlike Mr. Young's, is actually quite high, a bit like Steve Felicity was describing. So the access to the aorta isn't a big problem. And we just do routine cannulation with a flexible aortic cannula. We then, once we're cannulated and we're happy, we go back and we do the percutaneous femoral venous cannulation on the TOE guidance. I think that is actually, for us, that's been the most important or most difficult technique to learn. And I think you need to pay quite a lot of attention to get that right, make sure you don't have any catastrophes, and make sure your drainage is good. We use a standard cross clamp. You can use the flexible ones that are available, but we find the standard one works quite well. We use antegrade cardioplegia usually through the root, and again, I think it's important to have TOE guidance when you're giving antegrade cardioplegia, because that's going to be your first clue that the ventricle is blowing up, and if it does, we do exactly what Mr. Young described, which is just open up and directly cannulate the ostia. We routinely use the PA vent because it's there, it's easy. If the drainage is really, really good, I agree with Suki, you don't need it sometimes, but for big patients, we tend to find that we do, and it makes a big difference. And obviously, putting the valve in is just routine. It's a conventional aortic valve replacement. As has already been said, before you take the clamp off and allow the heart to fill, we put in our atrial and ventricular wires. We don't find this is a huge problem, really. Without incision, you almost always get good access to the atrium. The ventricle is a bit more difficult, but with a bit of care, you usually can do it. And we use a single drain, usually subxiphoid, but sometimes we bring it out of the left chest, particularly if the patient is very tall and very thin, and it's a very, very long way from the subxiphoid to the aorta. So this is our learning curve. I'm struck that this is sort of an expert talk, and people will be presenting great data about how fantastic their results are. And you don't get many people sort of turning up and presenting the learning curve data. So I'm presenting this data with that sort of caution, really. And the second caution is that we haven't really selected into this operation. Since we started doing the operation 5 months ago, Andrew and I have done 2 conventional aortic valve replacements, both of which have been for endocarditis. So we've just taken everybody, and that includes TAVI turndowns, obese patients, poor ventricles, etc. And the data reflects that. So again, the 27 procedures we've done in the 4 months or so, mean age of 71, we've done an 87-year-old. Most of them are men, as you'd expect. We've done some with a BMI of 48 and other patients with BMI in the 40s, so the mean BMI is 30. And we've done patients with poor ventricles, and the Euroscore reflects the sort of moderate risk nature of the cohort. It doesn't take a particularly long time. We always do this as part of a 2-case day, and that's reflected in the cross-clamp and bypass times. If it goes really well, it's a really straightforward operation. You can see there's a patient here who had a cross-clamp time of 44 and a bypass time of 62 minutes, and the mean valve size is size 22. So how have we got on? Well, we've had 1 death in a patient who had the operation and went back to the ward on the 3rd day, had an upper GI bleed, which is managed in the usual way, but was unsuccessful. He had a laparotomy and died from ongoing bleeding. We've had no strokes. We had an 80-year-old patient who came from the TAVI MDT with a Euroscore of 30 and a poor ventricle, who had respiratory failure, required a tracheostomy, but left hospital 17 days after the operation. We've had 1 conversion, and I'll talk a bit about that in a subsequent slide. We've had 2 patients go back for re-exploration for bleeding, and both those patients we opened the minimally invasive incision and did that. The first patient had a bleed from a sternal wire, and the second patient had an aortotomy suture bleed, which was fixed without a need for bypass. The 80-year-old accounts for some of these complications. So he had a filter. 2 other patients, other than the 80-year-old, had a balloon pump, and 1 other patient was ventilated for more than 24 hours, but was subsequently extubated and went home. It's very early, so we haven't really seen we've seen some benefits, but I haven't got good data to prove that. What we've noticed is that the patients are extubated fairly quickly, 7.5 hours on average. The postoperative blood loss is quite low, about 200 mils. The drains usually come out the next day. Postoperative length of stay, median of 5 days, which is interesting looking at the data from Suki's study. And some patients go home very early. We find that if in patients who are fit and well motivated, they go home in 3 or 4 days. We've had 8 patients do that out of the cohort of 27. So it's certainly a very good operation for that group of patients. Everyone has an echo before they go home. The mean gradient across the valve has been 19 millimeters. We'd expect that to be lower on the 6-week echo. We've had 1 patient who's had a paravalvular leak, and we're monitoring that and treating that conservatively. There have been no other significant findings on the discharge echoes. So what have we learned and what are our thoughts so far? We're very much on the learning curve. This is a new operation for us. We think the two consultants developing a program together has been a really good model and one that we'd recommend for anyone who's thinking of starting. We've avoided patient selection, and I'm sure we'll talk about this. And as Rex alluded to, some of the theoretical benefits for this operation will best be seen in the groups that are high risk. But I guess on the other side, you have to learn how to do the operation, and usually learning how to do the operation in low risk selected patients is a better way to go. But we've done all patients. We find that the operation is quite flexible. It's widely applicable. You can do ladies, you can do men, you can do short people, you can do fat people. We've been very, very pleased with how widely applicable the operation is. Our one conversion was due to inexperience, and the TOE support is essential. Essentially, in retrospect, what happened in this case was that the Seldinger wire had gone through the IVC and into the RV, and the cannula followed. It was actually a fairly straightforward conversion because obviously you've got your aortic cannula in already. You essentially have a venous cannula in. You just pull that back, you're on bypass, you complete your sternotomy, and you fix it. But it's really, really important that your TOE support is very good, and we've paid much closer attention to that going forward. When we've had to take patients back, we've done it through the mini incision. You've got access to most things, your cannulation site, your vent site, your aortotomy site. The things that you can't see are your pacing wires, unless you clamp the heart again, and your drain site. So those are the two things that can catch you out, but we haven't had that problem yet. And of course, I guess for all these operations, you need to think about what's going to happen when you need to open them on the ward or in intensive care. At James Cook, we have quite a lot of minimal access operations going on, about 150 cases a year of a whole range of operations. So we've got quite fixed protocols about how to manage these patients, but that's certainly something to pay attention to. So we're very early in the program. There's some potential benefits that we can see already, particularly length of stay, but also post-operative bleeding. We think it's a widely applicable operation to a whole range of patients. We think it's less invasive than the fourth space. I'm very impressed with the pictures that I've seen of the fourth space. We think it's probably easier than a thoracotomy, and overall we think this is quite a good approach. Thank you.